All right, let's get started. Good evening, everyone. Thank you for being here today. My name is Pauline Matindan Garcia. I am the Director of Care Transition for Livingston Memorial, DNA, and Hospice. I have been in a home health and hospice setting for about 10 years now and have been fortunate to be with Livingston for the past 3.5 years. As Director of Care Transition, I work very closely with our patient and their family as they navigate their options for home care. I find it very fulfilling and rewarding to know our patients can access the right level of care in the best care setting through Livingston. I will be moderating this presentation tonight. This is the fall prevention webinar. But before I introduce our speaker, I have a few housekeeping notes. So first, today's session is being recorded to be available on their website post-presentation. If you have any questions for our speaker, please feel free to use the chat feature on your Zoom app. Depending on how you have your Zoom set up, it should be on the bottom part of your screen. If you're using a desktop or a laptop, you should be able to hover your mouse over it for it to appear. You can type your comments or questions on the chat box and send it our way. We will do our best to answer all those questions during the presentation. After the presentation, we will also have all the questions and answers posted on our website. And lastly, if you run into any technical issues, please feel free to send me any of your questions, reach out to me directly using the chat function as well. So tonight's speaker is our very own Dr. Rick Esguerra. Dr. Esguerra has been practicing physical therapy for the last 4 decades, and Livingston has been so fortunate to have had Dr. Esguerra as part of our team for the last 25 years. In addition to patient care, Dr. Esguerra has been providing community education in our county through his collaboration with Ventura County Area Agency on Aging, as well as providing pre-operative education in partnership with local orthopedic surgeons and hospitals here in our county. He is also a long-term Camarillo resident, and in his free time, he enjoys spending time with his grandchildren and shares the vision of continued responsibility for the preservation of Ventura County. So without further ado, let's please welcome Dr. Rick Esguerra.
Evening, folks. All right, first of all, thank you for logging in tonight. And hopefully it's my earnest wish that I could provide you with some of the best information you can get for starting a fall prevention program and pave the way so you can initiate contact with your caregivers with regards to this. Now, fall prevention is quite a quagmire because studies have shown that there are interventions out there that could actually lower your risk of falling. But unfortunately, it cannot stop you from falling. So if that is your goal, you really need to be contemplating on putting in more effort in your endeavor if you wanted to start something like this. All right, so anyway, let's get started then. All right, so tonight, our platform would start off first with relevant statistics on falls. And we'll get into the causes of falls. We'll get into detail, very much into detail on the risks or what increases your chances of falling. That way we could try to provide interventions on how to reduce that risk. All right, so hopefully we can stick to that with the allotted time. There's quite a bit of information. All right, let's get started. All right, now much of this information is available at the Centers for Disease Control website. So if you'd like to go into their website, you'll see much of this information. Now, the trend for falls is getting worse. From 2014 and the projected 2030, they're projecting an increase from 7 to 12 million as far as injuries related to falls, and the correlating 29 to 49 million falls. That is an astounding number. All right. Now, here they break it down into 950,000 hospitalizations, emergency room visits, injuries related to the falls, in relation to the falls. So they break it down. And you can see there's also a great bit of number for people succumbing to falls. So it is quite significant. Now, you might also be wondering why the statistics are taken mostly from 65 and older. This is basically, it's taken from right after citizens take advantage of Social Security through Medicare. And that's why most of the data that's available right now is from 65 and older. All right. So if you take a closer look, the amount of what the government spends on this is really a burden to society. If you look at the billions that is spent under Medicare, Medicaid, out of pocket, it's staggering. And the statistics of how common it is even more staggering, with 1 in 4 older adults suffering from this. Is it preventable? I think it is. And we'll be showing that to you tonight. All right. That 1 out of 4 translates into 1 every 20 minutes who are injured after taking a fall. Now, if that doesn't scare you, I don't know what will. Oh, enough of the scary statistics. Let's have a look at how we could lower your risk, shall we? All right. Now, as far as the states, now this is one of the positive ones, at least. They have detailed some of the deaths that occur from falls, and California is very much at the, close to the bottom of the list, as you can see from this chart. So we don't exactly know why that is, although what I have noticed here is much of the states where there's a really high number of fatalities from falls are actually states where there is snow. So there probably is a correlation between slipping and falling in those states, but mine is just a conjecture. All right, so let's talk about what is a fall first, all right? Now, for people who are attending tonight, some of you might have had a fall recently or months ago or probably a year ago. So let's talk and try to determine what constitutes a fall. Now, I took this from a definition from the World Health Organization, some of them from dictionaries, and you'll notice that, let's read some of them. A fall is defined as an event which results in a person coming to a rest inadvertently on the ground, on the floor, or other lower level. That's important because I'm going to show you why that's crucial. Number 2, a fall is to leave an erect position suddenly and involuntarily. Next one is to drop oneself to a lower or less erect position. There's another word, that erect, showing how posture, static or dynamic, is really crucial. It's very important. The next one is a fall is a drop or a descent under the force of gravity. Obviously, I bet if we were in the moon, we wouldn't be talking about this that much. And the last one is a precipitous drop from a higher to a lower position, which may or may not be accompanied by injuries. All right, now, so we all know that if you fall, you end up on the ground, but you have to realize too, that any drop from your level shoulder level, or pelvic level. When you fall, even if you rest on the wall, you rest on a chair, or you rest on the sofa, that is considered a fall. And one of the things from the definitions is inadvertently, involuntarily. That means it's unexpected. That means it's unplanned. It just happens all of a sudden. It cracks me up when I see places on websites saying that you can prevent injuries by planning your fall. I tell you, you cannot plan a fall. A fall will happen just like that. And during my younger years, I studied judo. And it takes years to develop a reflex action so that when you fall, you can prevent yourself from getting injured seriously. It takes years to do that. So for someone to come and say, oh, you can plan a fall by falling on this side instead of that side, or falling one direction instead of one direction, I think that's far-fetched. So please, when you read things on the internet, be careful. Some of them are not truthful, or they might deceive you from giving you that information. One particular one that I like is that you can train someone to cover their heads if they happen to lose their balance. Now, it depends on the descent, how fast it is. If you go down really hard and fast, you're not going to be able to react fast enough. However, if you lose your balance, I'm losing my balance, that's the time where you can actually cover your head. That's one of the most serious injuries that you can sustain from a fall, a head injury, a traumatic brain injury. So if you can protect your head, you can probably sacrifice your wrist or your shoulder or even your hip, but not your head. Anyway, we're going too ahead of ourselves there. All right, so let's have a look at some of the risk factors. Now, you might have read this in several articles about fall prevention, risk factors. Now, it all sounds very, very scientific when they say risk factors. Basically, what this means is that we're trying to see what increases your chances of falling. All right. Now, I prepared three cues here, three rosters here. One is from the geriatrics book, another one from the CDC, and another one from a European study. Now, if you take the time to examine some of the entries in this list, in these three columns here, you will see that some of them overlap. An example here is, let's say, if you take a look at the number of chronic pain sites, and you will see pain, you will see prior falls, you will see drugs or medications, you will see comorbidities or chronic conditions. One of the lists will say multimorbidity, and others will say chronic conditions. They all mean the same thing. And it is my attempt tonight to go over some of these most important risk factors so you can see for yourself, do I belong to one of these risk factors? Does this increase my chance of falling? And if it does, how much? How much does it increase my chance of falling? All right, so let's get started in seeing one of them. Now, vision obviously is one of the big ones, all right? And as we get older, we get afflicted with several conditions that might impair our vision. We could have glaucoma, we could have macular degeneration, cataracts, retinopathy, and here are just examples of some of the ones that I wanted to show you. On the left is you see a nice clear vision of a couple of kiddies. On the right is an impaired vision with someone with cataracts. And you can clearly see, which is quite an oxymoron, that your vision is pretty blurred. So this actually implies that you can't really see clearly where you're going or what you're stepping on or your pathway. Now, another type of thing is macular degeneration. Here, I happen to see this, and I want to show you when macular degeneration starts from minor to severe. And with macular degeneration, you actually miss a big spot, a growing spot in the middle of your visual cue. And as it gets worse, it begins to completely block your vision. Now, obviously, if you're visually impaired and you can't see where you're going, your chances of falling goes way up. So if you are, and here's one thing too, before I proceed. Most often when physical therapists do an evaluation, we often ask, how's your vision? Most of the time we'll have someone say, I'm fine. Oh, I wear glasses, but I'm all right. But is that enough? So I beg to say that probably if you have impaired vision, seek help from an optometrist, an ophthalmologist, so they can clearly address your situation right away. At least if it's already starting, if we can arrest that situation so it doesn't get accelerate or proceed any further. If you try to preserve some of the periphery of your vision, obviously it will help you reduce your risk of falling. All right. I didn't include some of the other conditions, but they're quite similar. In glaucoma, it's sort of it's the opposite. You have the outside periphery that's getting blocked. If you have retinopathy, you'll have sort of patches all over. So no matter what it is, visual impairment would require some attention to reduce your risk. All right. All right. Now, this next one is a big one, and I have several slides, but I'm not going to go in it so much detail, but rather just show you certain medication groups that you have to be aware of that could actually alter your balance. It could actually affect your way of walking. All right, let's start with the first one, anti-diabetes agents. If you're diabetic, that's obviously a very bad disease process. It is progressive. You will see that one of the risk factors is a lowering of your blood sugar to a dangerous level, hypoglycemia. All right. If you inject yourself with insulin, that could cause a momentary or a prolonged reaction of lowering your blood sugar. And that's why, as physical therapists, we try to not to do your exercises right immediately after you have your insulin, so that at least we can have a little bit of a lag that you can absorb and insulin take effect first before we start the exercises, which also has a way of burning sugar. So it might accelerate the downward slope of your glycemic levels. So just bear in mind that if you are diabetic, there are certain agents that could cause you to hypoglycemia. Now, what about hypoglycemia? Well, it could cause dizziness, it could cause blurred vision, it could cause tingling, it could cause different types of symptoms. So in other words, it could affect the way you perceive yourself in relation to space. All right, let's go on to the next group. A lot of our elderly seniors will have medications for their heart, all right, for their beta blockers, alpha blockers, and the risk here is the lowering of your blood pressure, and it's called orthostatic hypotension. All right, now we could test this, by the way, and when we get to the assessment part, I'm going to show you how we can test for this. Another risk factor here, obviously, is dizziness, syncope, a slowing down of the heart. And when they say impaired cerebral perfusion, since it lowers the pressure, it could lower the pressure pumping up through your carotids into your brain. And that could cause some vertigo-like or dizziness or lightheadedness, which could already cause you to lose your balance to begin with. All right, it could precipitate a fall right there and there. So that's another risk increasing medication. Let's go to the next one. This is a continuation. There are also cardiovascular agents, calcium channel, antiarrhythmics. If you have atrial fibrillation, if you have some kind of dysrhythmia in your heart and your, let's say your cardiologist has given you something to control the rhythm of your heart. If you have a diuretic, let's say you have lower extremity swelling, and your doctor is attempting to reduce the volume of the fluid inside your body, these are diuretics. And this could also cause hypotension, dizziness, and all that. And this is now a direct cause for people losing their balance. All right, let's go to the next one. Next group. It continues with the diuretic combinations with diuretics and blood pressure medication. All right. So there's quite a long list. And we're not going to bore you with going through each one of them, but I'd like you to at least have an idea of the groups of the medications. And then you have the what it's called the psychotropic agents, and these are for anxiety. All right, most people have anxiety, and they're taking some of these medications. And some of these, you also might have antidepressants that might sedate you. And it's just it's got the same thing that might cause orthostatic hypotension. Sedation is you'll feel sleepy, right? You feel like you're falling asleep. It could cause a psychomotor impairment, meaning it could cause you not to perform with your muscles in the correct way. Dizziness is quite common. All right, so let's go to the next group. This is a big one. Pain in itself is a risk factor. So what does the doctor do to help us with pain management? Of course, pain medication. And the big one here is opioids, all right? And most recently, I've seen when reviewing charts that when people are given opioids, they're also given an antidote for an overdose to opioids, because it's quite easy to overdose on these medications. And it's these are considered high-risk medications, by the way. All right. Now, this might cause psychomotor impairment, sedation, and the worst is it might cause some confusion if taken in the improper amount. All right. Let's go to the next one. Again, we still have some analgesics, non-steroidal anti-inflammatories, Celebrex, Voltaren. There's even the over-the-counter Advil or Motrin. Some of these can cause some of these risk factors to increase. Some of the medications for relaxing muscles that could also cause some psychomotor impairment. All right, let's go to the next one. Anticholinergics, they basically control the acetylcholine in the body, and some of these can cause sedation. That's the most common thing. And when you take these medications, sometimes you feel like you're falling asleep. And obviously, if you feel sleepy or lethargic when you're trying to walk, that's a risk factor. By the way, from my humble years of experience, every time I see a sleep aid like Ambien, I've seen people fall when they're on sleep aids. So people who can't sleep, have insomnia, they take these medications, they sort of go forward until the time that wake up in the morning, it's still in effect. So you don't wake up refreshed, but you wake up still groggy from the effects of the medications. So watch out for these sleep aids as well. All right. The list continues on and on. There's muscle relaxants, right? And seizure medications, right? If people have brain injuries or you have a seizure disorder, you might be prescribed some anti-seizure medications. This can also cause a risk factor as well. So you can see that from medications, different medications would cause different risk factors. So it's important for you to check with your doctor if you notice anything unusual after you've taken a new set of medications. It's a good point. So let's say you were prescribed something new. It'll be a good idea to keep track of that. If you take it, let's say on day one, what happens the next day? What happens the next few days? Are you developing unusual symptoms? This might lower your risk by seeing what's happening immediately after taking some of these medications. All right. We talked about the anticonvulsants, and again, it might cause sedation, sleepiness, confusion. All right. Now, the next risk factor and somewhat that list is hazards in the home. How'd you like to, let's say you go into the hospital and you come home to your place and it looks like this. Now, I'm not implying that your place looks like this, but I have been in situations where we're trying to keep patients from falling, and yet we see this when we get to the house. And obviously, we take the initiative to try to correct some of these things. You notice there's a wet floor, there's an electric cord, there's open cabinets, there's a knife, there's a lit cigarette, there's cooking that's probably not being attended to. There are cords hanging over the edge of the cabinetry. There's open door cabinets. There's a pet with a bowl. There's a burnt toast somewhere. So anyway, the reason I included this slide is to show you visually that this alone increases your chances of falling. Now, if you request a list of how to go through your whole home, with your whole house, on how to go about eliminating some of the risk of hazards in the home, we can provide you with that. But I just wanted to do this simple slide so you'll get the picture that you could take the initiative to lower the risk of falling at home. And by the way, the statistics of falls, actually, it's most falls occur in the home, not outside the home. All right. So, all right. Now let's go into the individual types of risk factors that we could identify as. They're called comorbidities, or if you're afflicted with any of these problems, you will notice that it increases your risk 2 or 3-fold. It increases your risk significantly. Now, when you have a stroke, unfortunately, statistics show that only about 10% will recover fully. 25% might recover with a slight impairment. A whopping 40% would recover with a moderate impairment requiring assistance, and they will be depending on someone for activities of daily living. And the next 10% probably won't recover at all, and 15% will probably succumb to the problem. Now, I'm not trying to scare people who've had a stroke, and it's not really that there's nothing you can do, but we just need to make sure that we provide some real information to you that a stroke is really increases your risk of falling, or your chances of falling, quite a bit. The prevalence of falls during the first 6 months after discharge from hospital is between 36 to 73%. And then after a year, it remains high between 40 to 58%. So the statistics are not very encouraging. So if you understand that after you've had a stroke, that the risk is really high, then it really gives the families, the caregivers, and even the patient some warning that fall prevention has to be way up there in the goals. It's not just teaching someone as a physical therapist. It's just not my realm to try to provide treatment on how to get someone to walk properly, getting up from the bed, getting up from the chair, but actually do no harm with the Hippocratic Oath. I'm not going to encourage someone to just say, oh, you can do it, get up and walk all the time. I wouldn't do that. I would often side with the being cautious after a stroke. All right, let's go to the next condition. All right, arthritis. Obviously, if you have osteoarthritis or even rheumatoid arthritis. Now, rheumatoid arthritis mostly afflicts smaller joints, but osteoarthritis affects mostly the bigger joints, hips and knees, and ankles too. And so in a study, the prevalence of any fall, 2 or more falls, or a fall injuries in the 12 months was significantly higher among adults with arthritis compared to those who don't have arthritis. So that means arthritis in itself is a risk factor. So think about this for a second. You go see the doctor and you say, "Hi, doc, I'm feeling a lot of pain in on my knees, on my hips. Can you please help me with relieving some of that pain?" The doctor gives you pain medication. As we've seen, the pain medication actually has potential for increasing your risk already. Now, arthritis in itself is also a risk factor, right? And also pain is a risk factor. So now you see it magnifies itself. And so you count those as risk factors. Now, you might be saying that, oh, this webinar is just doom and gloom. No, this is reality, folks. What I'm trying to establish here is we have to be very scientific with identifying the risk factors so that we could intervene and address these risk factors independently. All right, so that's basically why I'm doing this. All right, so arthritis increases your risk significantly. All right, let's go to the next one. I was just mentioning earlier, pain. So pain and arthritis somewhat, they go together, don't they? But then, like I said, if you happen to have pain medication that alters your balance, then you added another risk factor. So you have to address that as well. So how do you address that? Well, we'll talk about that in the interventions part. All right. They did a meta-analysis, by the way, is a group of studies. So they look at a group of studies to see if there's correlation between different studies. This one, it just says plainly that adults with pain have increased risk for falls. And it says here the study found that 50% of adults with pain report 1 or more falls in 1 year compared to just a quarter of those without pain. So it's a very significant statistic that patients with pain have an increased factor. Now, here's another risk factor that you have to think about. Where is the pain? Now, if I tell you, oh, I have pain in my shoulder, would that be the same risk factor as if I tell you, I have pain on my hip? Now, I'd like you to think about that, because when you're walking, you are putting weight on your hip. You would probably be putting weight on your shoulder if you're using a walker or a cane, of course. But if you're walking without any assistive device, having pain on the lower extremities adds more risk that, let's say, you have pain on your finger, right? So that's where it is. Now, whenever you go see the doctor or your primary care doctor, and you say, "Can you please prescribe me something for pain?" Your doctor is focused mostly on my patient needs some relief from the pain, obviously, right? But the thing is, we have to take an extra step, no pun intended, but that extra step is, all right, this pain that this patient is complaining about is actually a risk factor. So a full risk assessment is already indicated. Is that a normal flow? I venture that it's not. It's not a jump that a lot of people think about. They think about, I'd like to have a relief from pain, but no one's thinking about, well, this is a risk factor for pain. But tonight you're discovering that these are all individual risk factors. All right, let's go to the next one. Parkinson's disease. Now, some of you might have this condition, and the statistics might be something new for you. Up to 68% of people with Parkinson's fall each year. That's a pretty high number, 68%. And 50% falling repeatedly. So 1 out of 2 people with Parkinson's would be falling more and more or repeatedly. And that's why a fall intervention, fall risk prevention program is definitely an indication for someone with Parkinson's. There's been a lot of breakthroughs with medication. Unfortunately, the medication will help tremors and some of these symptoms, but it does not really lower the risk they found in falling. Now, what has it, some of the studies have shown, what does it control? Freezing. So we know that some of the devastating effects of Parkinson's is the freezing. When you're walking, when you're trying to cross a threshold, you freeze. Now, believe it or not, some of the exercises are helping in reducing some of the freezing. And there's also some new equipment nowadays. If you need some information about that, we'll be more than happy to share it with you. There are some walkers now that help give you visual cues so that you could reduce some of these freezing moments. All right, but anyway, the reason I included this is this is a very important risk factor to consider for fall prevention. All right, let's go to the next condition. Now, this one might surprise a lot of people, right? Depression. They might be thinking, what is this depression got to do with falling? You'll be surprised. Because, you know, when people are depressed, what are the correlated symptoms when someone is depressed? Well, you have a low energy level, low activity, you have weakness, your reaction time slows down, poor balance, your walking speed decreases, and occasionally cognitive impairment ensues. So all these things add up to increase the risk of falling, and studies have shown there is the strongest association with falls than all other characteristics. I couldn't believe it when I was reading some of this information. I couldn't believe that depression is one of the highest risk factors from falls. Now, remember what I talked about when you get prescribed medication? Now, antidepressants is also a factor. So you have to score, all right, I got an antidepressant for my depression. Number 2, I also have depression. So that's 2 risk factors right there. So we have to address both of them. All right, we have to address making sure that you are taking your antidepressants the right way, the proper way. And we have to get you starting to be more active when you start having depression symptoms. That's one of the ways that we can try to push back on the depression symptoms, is increasing your activity level. Hopefully in that way, we could lower the risk factor. The posture. Do you remember that first slide we were looking at as far as the identity, when we were looking at the definition of the falls? And 2 of them were mentioning about the erect posture. Now, when someone is depressed, what do you normally see? You start to see a lowering of the posture. You begin to see someone coming out of that erect posture from a perpendicular posture. You begin to lean forward. Now, when you lean forward, you are leaning away from the center of gravity. That increases your chance of falling. Right there. All right. If someone is straight, you are steady. The moment you lean forward, you already increase your factor right there. And that's why, as a physical therapist, the first thing I look at is just posture. As simple as that. Now, it's easy for me to say to someone, can you please straighten up? But unfortunately, it doesn't carry over. It would require cueing, and it would require all the love and all the support from your families, from your caregivers, to always remind you, please straighten up. Let's straighten up. And hopefully it will be enough initiative for you to do that, so you can lower some of the risk factors. All right, let's see if there's some more of these conditions that we're talking about. Now, this one is a minefield, dementia. All right, now, nowadays, physical therapists and doctors and nurses and occupational therapists have tools to assess the severity or the level of dementia. If people are diagnosed with one, or if we suspect that someone has dementia. When I was seeing patients, I would often encounter some of our patients who would follow instructions very well, converse perfectly, but I could not pinpoint something that's wrong. There is something wrong about me not connecting fully with certain individuals. And usually it's the beginnings of dementia. Now, with dementia, we look at the domain of cognition, what is affected, right? So there are different domains in cognition, and one of the domains that are affected in dementia is the executive function. Now, executive function basically is, it sounds like a very hierarchical name, but basically what it means is that there are certain things that a person with dementia will begin to deteriorate. And three of these things is the way they perceive things and how they cross-section movements. Now, do you everyone in this webinar, do you believe in multitasking? That's a word that's been tossed around for quite some time now. And people seem to think that they're awfully smart because they can do 2, 3, or 4 different things all at once. Well, they're mistaken. There's no such thing as the human brain doing 5, 6, 7 different things at one time. Reminds me, on my way here, I was on the 101 freeway, and there was a bit of traffic. And looking to the right, there was this lorry, there's this truck, and there's this driver in the truck eating spaghetti as he was driving. I said, "Whoa, no wonder we're riddled with accidents all over the freeway." Now think about this for a second. This person is eating, driving, his hands on the steering wheel, and sometimes not, probably listening to the radio. He has to pay attention with the position of his feet, turning, looking at the side mirrors, rear view mirrors, all that. All these things are happening in real time, and he has to do this all at once. He's not doing it all at once. He's doing it in sections. Now, why am I saying this? It's because this is the same thing you do when you're walking. You're not just aware of it, but your brain has this domain in cognition where it's taking every bit of action in real time and breaking it down. Unfortunately, with dementia, you begin to lose that ability, that capacity to do all that different sections of time. I'll give you an example when you're walking. When you're walking, you're paying attention to your posture, you move your left leg, and then you move your right leg, and then you swing your body, and then you have to veer away from objects. You have to look at the floor and look at the texture of the floor. You have to lift your hip, and you have to turn if you have an obstacle. All these things are happening to you, and unfortunately, with dementia, you begin to lose those perceptions, and that's why dementia is a a big risk factor with falls. Let's read this for a second really quick. The risk of falls in older adults is more than twice as high as that among cognitively intact elderly. And remember, it's easy to test. We have tools now, not mechanical tools, but tools that we can have you do, ask you questions, questionnaires, and forms that you can do. We can actually see and assess this, because it's important for us to realize if we have the beginnings of dementia, if you have moderate dementia, and if you have severe dementia, because the more severe it is, the higher the risk factor. All right, let's go to the next one. All right, so where do we go now? So we have looked at all those devastating things that we talked about. So we identified the comorbidities, right? So we're trying to screen you now. Now we evaluate. As a physical therapist, this is where we come in, is where our forte is. We evaluate your gait, your walking, we evaluate your strength and your balance. All right, there's three dynamic tests that we do that's quite unique. It's called the TUG, or the acronym stands for Time Up and Go. We have the 30-second chair stand test. We have the 4-stage balance test, right? And I'm gonna demonstrate that in a few minutes. Then the next one is we identify your medications, because it's such a big list. We have to identify which medication could be causing you to have not good balance, or how is it affecting you. We identify home hazards. I just showed you that clip, that picture of a house with cords and pets and all that. We check visual acuity, right? Make sure your vision is fine, because like I said, if you can't see where you're going, chances are you're going to take a tumble. We check your vitals, all right? With vitals, with orthostatic blood pressure, we check it with you lying down, and then you get up. And we compare the systolic, that's the first number in your blood pressure. Remember blood pressure, let's say, the first number and the second number. We compare the first number. If there's a drop of 20 millimeter mercury and you say, oh, I'm dizzy, you have orthostatic hypotension. That's an added risk right there. You might see yourself getting up and taking a fall. We look at your diastolic blood pressure. If there's a difference of 10 to 20, we take note of that as well. Now, what do we do with that data? We contact your doctor, and there might be a possibility your doctor might adjust your blood pressure medication. See, that's really where it is. We have to be fine-tuning everything that's happening to you. The next one is assess footwear. Oh, it is a big one. We didn't include that in that list, but footwear is a big one, because a lot of people fall because they have lousy footwear at home, or even if they go out, this is how they trip. All right, so we'll talk about it in a bit. And then there's vitamin D, of course, for the strength of the bones. This is mostly for protecting your bones from breaking if you do take a spill. All right, let's try and see if we can do the evaluation for gait, strength, and balance, shall we? We'll do it really quick. All right, the first one is the timed up and go, or the tug test. I'm going to show it right here on this chair. Now, don't do this yourself. Let your professional do it with you. All right. So we measure 10 feet or 3 meters from here up to there. We have you sit down. We have a stopwatch. All right. When we say, that's always got time up and go. When I say go, this chair is supposed to be arms. So let's pretend it's got arms. All right. So you get up with your arms. You walk 10 feet. Now I'm clocking you. You turn around. And you sit down. How easy is that? Now, don't underestimate this tug test. This is proven. and they have accumulated data over decades and decades of people doing this type of test. And it's quite accurate and could actually give us information if you have an increased fall risk or not. Now that number, just to give you an idea, would fall around 13.5 seconds. If you can do that between 13.5 seconds, that's fine, right? Of course, there's a little bit of nuances with age, also with gender, right? But mostly it's about 13.5 seconds. So if it takes you more than that, now 13 seconds is a long time. 1001, 1002, 1003. So 13.5 seconds is a long time. So if it takes you longer than that, it increases your risk. Now we also might do that even if you're using an assistive device like a walker or a cane. All right, let's go to the next one. The next test is the, let's go to the next test is the, let's see, the 30-second chair stand test. All right, now from how it sounds, 30 seconds, it takes 30 seconds to do this test. So basically, you're going to be sitting on a chair, all right? And I have a stopwatch again. 30 seconds, you're going to be getting up without using your hands. No hands allowed. If I see someone using their hands to get up, we can't do the test. All right, so this one, person gets up and does this repeatedly for 30 seconds. All right, 30 seconds. There is a set number, an acceptable number, a normative value, where when someone does a certain number after 30 seconds, that means you're good. But if you do a lot less, that means that strength could be a problem. You can just picture, if I'm clocking you at 30 seconds and you only manage to do 1 or 2, that is not a good sign. If I see someone even doing this, oh, I can't get up, right? Now, you could have pain in your knees, pain in your hips, pain in your back that prevents you to get up. So these are some of the things that we look for when we're testing you and evaluating your mobility, all right? So this is a measure of strength and also a bit of endurance, right? Because if you say, all right, you got up nicely, and after about 2, I'm short of breath, and then that's something different, all right? We have to address that as well. The third test I'm going to try to demonstrate to you is the 4-stage balance test. All right, now from the name 4-stage, right? This is how it looks like. Now we have a stopwatch. You know, notice everything is time related. The first one, we time you 10 seconds standing with your feet together. So first you hang on to something, and when I say begin, let go. So you're going to stand for 10 seconds. You should be able to do that. Your feet are together, all right? Now, let me back up a little bit so you can see my feet there. Right, there you go. Right, so this is 10 seconds. Once you pass 10 seconds, we go to the next one. This is semi-tandem. Your feet will be overlapping like this. All right, so your instep is going to accommodate your forefoot or the front part of your foot. That's going to look like this. Just like that. 10 seconds. You should be able to do that. 1, 2, 3, and so on. After this, you go to the most crucial one, tandem standing. Tandem standing is when you have one foot in front of the other foot, heel and toe in contact, like this, all right? You can balance yourself, but don't do this. That's a different test. That means you got pulled over. Right, I'm just trying to give it a little light there. But anyway, this is the tandem test. This is the most crucial one with this test. If you cannot do this for at least 10 seconds, your risk of falling, because you cannot maintain static balance, is huge. So we got to work on it. See, we're not just doing this to determine your risk, but we're trying to determine what we're going to work on. If you are strength deficient, we work on your strength. If it's static balance that you need, we'll work on that, right? All right, so I hope everything is beginning to form like a chain here. All right, so I've demonstrated a few of the testing we do and how we're trying to connect all of them together. All right, now let's go to the next slide. And what do we do? What is next? So we have identified the comorbidities or some of the disease processes or some of the potential medical conditions that a patient might have. Like we mentioned stroke, we mentioned Parkinson's disease, we mentioned arthritis, pain, dementia, depression, to name a few. And there are others too, but we can't. We're short of time, so we're trying to include the ones that are commonly seen. All right. So we've identified them. So we optimize our approach based on that. So we're not just going to come in and say, all right, do your exercises. Here's a couple of booklets. I'll see you later. No, we're going to have to actually fashion your exercises based on your comorbidities. If you're a stroke patient, we have to strengthen the weak side that has been affected by your stroke. If you're a Parkinson's patient, we have to always time your medications with your treatment. All right. Improve your coordination. If your gait and balance is poor, of course, physical therapy. The occupational therapist can help with home hazards. All right, if your house needs some improvement as far as flow, all right, the occupational therapist might be able to help you there. The doctor, of course, I told you, we report if you have orthostatic hypotension that is an effect from your medications, or if you have a condition that's causing you to have some changes, aberrant behavior with your blood pressure. We report that to the doctor. Hopefully, then you'll be as a team you'll be addressing that. Visual impairment. We talked about getting you referred to an ophthalmologist. Footwear, we're going to talk about that in a bit. Traction is important, of course, so you don't slip. Vitamin D, of course, your doctor will check if you have some deficiencies there. Make sure you're getting a decent amount of that to take care of your bones. All right. And here's that last one right there is extremely important. Follow-up should be consistent. So if you embark on a fall prevention program and you have contact with your caregiver, your physical therapist, occupational therapist, or your doctor, and you never see them again, or you see them once every few months or so, it might not be the proper way. You need to have consistency in follow-up with these things. For example, if I say, are you interested in a fall prevention program? Let's say I'm talking to Mr. or Miss Smith, and this patient says, right, I think I am. All right, so you're interested in it. And we start something, then there has to be some intent on following this through. And we can't force it on people, obviously. If someone says in the middle of the road, they say, I'm not interested in this anymore, I'm tired of it. And there's nothing we can do. We're going to try to convince people to keep on going because you haven't fallen, or instead of falling 10 times, you've only fallen once. But of course, sometimes we cannot force anyone. The old saying, we can lead a horse to water, but we can't force them to drink, that sort of thing. So what I'm saying is follow-up should be consistent. And this is what basically a multifactorial approach is. It's multidimensional. It's not just one thing. It's a lot of things that you have to connect the dots with. All right, hopefully that's making sense. Let's go to the next slide. All right, a word about footwear. All right, this one, I had to really look deep into this. And I'll read it aloud for you so you could, I'll share this with you. Footwear may also be a predisposing risk factor for falls. A small lab study testing balance in older men using various shoe types found that shoes with thin, hard soles were associated with best balance. And athletic shoes were also a good footwear type. However, increased heel height and a decreased surface between the sole and the floor was not a very good design. So keep that in mind. So if you're aiming for a very narrow shoe and with heels, not a very good one for, I hate to say that, ladies, but it's not a good design for footwear, especially if you're running a high risk of falls, right? Another article says that older people going barefoot, wearing only socks, wearing only slippers, especially the loose type, the ones that are broken in, it's all fuzzy, and your foot can turn around in there. Those are not very good. And it shows you that look at this study, 765 participants, more than 50% fell with these things, wearing socks, barefoot. I guess I venture to say that with wearing socks and barefoot without any sort of traction, you could easily slip. That's my guess here. All right. And for those who fell, they had 2.27 greater odds of having a serious injury. That's another thing, by the way. One of the biggest reasons why the CDC is studying this based on morbidities is because if you have a fall, you are now at a very high chance of having or sustaining another injury, a broken wrist, a broken hip, a cracked head, lacerations, it goes on and on. And so if we can keep you from having serious injuries, I think half the battle is won, don't you think so? I think it's important to, if you have a progressive condition, delay that condition. If you're having a condition that's starting, let's arrest that condition. If you have a condition that could be addressed with medications, let's address it with medications. If you have medications, let's see how we can educate you and take them properly. So all these things now are being linked into one solid approach, not just one intervention. All right, let's go on to the next slide. All right, so we finally get into an exercise program that has been proven. It's been tested quite significantly. There's full randomized tests that have tested this exercise program called Otago, right? It's how it's pronounced, it's how it's spelled, OTAGO. If you go to the CDC website and you go into the compendium or collection of fall prevention interventions, right? This is listed close to the very top. I think it's like second to the top. And the reason I chose this is because it has been randomized testing. There's quite a lot of empirical and rational evidence that points to the fact that these work. All right, so I'm going to show you some of it. Now, this originated in New Zealand. I think it started way back in 1995. And these exercises as a group of 17 exercises that are warm-up exercises, strengthening exercises. They also have balance exercises all in one. And another thing that really attracted me to this exercise program, and that's why I chose this for tonight, is I have been doing some of the exercises without me knowing it. Not the whole full exercise program, but a lot of them were basically the same. And I said, well, if it worked for some of the patients I've seen in the past, then no wonder it worked. So I'm going to show you some of it, all right? And basically these type of exercises are designed for home use, meaning someone comes to your home and you're shown these exercises. Of course, you can do it as a group too, don't get me wrong, but the design was mostly for people in their own homes. They have family members who will participate. They do the exercises, and they do it for months and months. And the studies have shown, get this, it has reduced the incidence of falls by 35%. That's 1 out of 3. So if you were going to, if predictably you're going to be falling 3 times, it cut it by 35%. That's significant. All right, so let's have a look at some of the exercises that in Otago. All right. These are some of them, and you can see one involves squats, gentle squats. And the one thing I like about these exercises is they're progressive. No, that's progressive. That's not the political term. Progressive meaning it's you make the intensity, you make the difficulty, the degree of difficulty harder, right? You make it more challenging for the person who's doing it. Now, if you look at that squatting, the first time you do it, you're hanging on to something, and then later on, you progress to doing it without hands. All right. Now, the next one, you're doing walking with support, backwards walking with support, and then you walk backwards without support. The next one, you do tandem walking with support, and then you're doing it without support. You're doing the figure 8 walking, and you're doing the side-to-side walking. So these are some of the examples of Otago. And there's the next one, which is this is strengthening. We use weights for this one. This is basically you strengthen the quadriceps, and you do the sit-to-stand exercise. You notice that the sit-to-stand is one of the tests we did. And it's actually one of the treatments, one of the exercise programs that's included in Otago. But it's a very nice program, very simple, low budget type of exercise. You don't need any fancy equipment. And the most important part, it's proven to work with randomized clinical trials. All right, and finally, what happens if you do fall? Now, there's two. I used to teach this at the Ventura County of Aging Agency. What happens when you do fall? There's 2 techniques that we could demonstrate to you really quickly, and that will probably wrap up our presentation for tonight. And the second one is using your arms. You have to be creative, and basically these 2 techniques is to get you back into the level where you're sitting, or at least on your knees, and get back to a sitting position. And if you need some further information about this, we can certainly assist you with learning how to do this. All right, that was a long one, wasn't it? So open the floor for questions and answers, questions from the audience.
The audience can also feel free to unmute if it's easier to unmute and ask your question directly to Dr. Sierra instead of sending it in the chat. That would be okay too.
All right. All right.
We posted the Otago exercises, a PDF format. It's in the chat box, available for download for anyone who are interested. We will also post it on our website as part of the materials for the presentation.
All right. Well, if there are no questions for tonight, it's been a long presentation. It's been a pleasure to provide you with some of the information. And we'll part ways by saying that I hope that you can initiate a program that will help you. It will pave the way in you starting some kind of program so you can prevent falls and also prevent injuries. All right. You have a good evening, folks.
Thank you, everyone, for attending. Please feel free to reach out to us if you have any follow-up questions. You can send it in the chat box, and we'll connect you with Dr. Esquera on a one-on-one basis. Thank you. Have a good evening. Bye-bye.